This is the start of a 4-part series introducing us all to global health. What is global health? The Consortium of Universities for Global Health says that it's an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, and involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual clinical care. So this is a course focusing on how engineering and engineers engage in global health. But global health is not a different discipline. It is inclusive of engineering. It's inclusive of medicine. It's inclusive of public policy and many other disciplines. And this definition clearly highlights the multidisciplinary elements of global health. So in this lecture series, we're going to look at the determinants of global health, including the social and economic determinants that impact health and impact health disparities between high and low-income countries. And we're going to look at those differences in disease and life expectancy, or morbidity and mortality, between high and low-income countries. And we're going to look at some of the dynamics, the macro-level dynamics in developing countries and between countries that impact health trends. Here's a few concepts in global health that we're going to review. The determinants of health, the causes of health differences, the measurement of health status, the measurement of morbidity and mortality, or disease and life expectancy and death, the importance of culture to health. You know, a lot of engineers, when they enter this work, they think that it's simply a question of access to a technology and knowledge that the technology can help impact your health. It's a lot more complex than that. We're going to look at the global burden of disease, which is a measure of disease, including disease sickness and also sickness that leads to death globally. And we're going to look at the key risk factors for different health problems. And we'll briefly look at the organization and function of the more formal health systems, although some of that will be left to other courses. So there's lots of different disciplines that are involved in providing global health. Of course, it's public health professionals, but it's also engineers, it's political scientists, it's social scientists, anthropologists. Of course, local communities are engaged in impacting their own health. It's the medical and the doctors and clinicians that work in health that all have an impact on health interventions and in measuring health impact and in creating interventions and policies that impact health. Here's a few examples of disease that disproportionately impact people in developing countries. Malaria is a parasite that is carried in mosquitoes, and it actually has the distinction of being the single greatest killer of anything in all human history. It's killed more people than war or old age or stroke or heart disease or anything else. Malaria has killed more people in all human history, and it's a parasite carried in mosquitoes. Diarrhea is a major cause of illness and death globally, and it's often or predominantly associated with contaminated drinking water and poor sanitation. Pneumonia and other respiratory diseases are often or predominantly linked to both indoor and outdoor air pollution, and HIV and AIDS predominantly at this point affect people in developing countries. Here's a statistic I want to stick in everybody's mind, and if it's the one thing that comes out of this series, you've learned something important. 99% of the children under the age of 5 who die every year lived in developing countries. 99% of children under the age of 5 who die every year lived in developing countries. And we can start to see that in this chart. This is life expectancy by country income levels. You see at the top high-income countries and at the bottom low-income countries. And as you get older, it converges. There are few survivors beyond the age of 100 in any group, although still in high-income countries you're going to have more 100-year-olds per 100,000 live births. But you have a particular susceptibility at the lower end of the age groups. People under the age of 5 are particularly susceptible to death in low-income countries. And you can see that here. This is mortality in children and adolescents between 1990 and 2000, and the top 5 causes of death by age group. This is from healthdata.org, which is the Institute for Health Metrics and Evaluation. We're going to review their website in a moment. But look here at developed countries in the top charts. For kids under the age of 1, congenital anomalies, preterm birth complications, neonatal issues are the leading causes of illness and death. Of death. If you look at ages 1 through 4, you still have congenital anomalies as the number 1 cause of death, but then road injuries is the number 2 cause of death in children ages 1 through 4 in developed countries, followed by drowning. If you look at the bottom chart, it's malaria. Malaria is the number 1 cause of death, followed by lower respiratory infections, again often associated with indoor and outdoor air pollution, and then diarrhea. So if you were born in a developed country and your biggest risk as a kid is a congenital issue or a road accident. If you're born in a developing country, it's an issue of being bitten by a mosquito carrying malaria and not getting treatment, or having air pollution or diarrhea caused by dirty water or dirty sanitation kill you. Here's another way of looking at some of this data. This is death rates by age group according to region. So you see in the top bar in all 4 charts for each age group, you see Africa, and in the bottom you see Europe, and then in green you see the Americas. So if we again look at ages 1 through 4, in Africa you have over 2,000 child deaths per 100,000 children. And in America and in Europe, it may be closer to only 200 or 100. This is another chart from healthdata.org showing what's called the global burden of disease. In the top, you see high SDI countries, high socio-demographic index countries, rich countries. And this is showing a metric called DALYs, or DALYs, Disability Adjusted Life Years. It's a really weird metric. A disability adjusted life year is an attempt to aggregate all of the causes of disease and the impact of disease or injury on lost time or lost years. So one disability adjusted life year might be one person having a stroke and not being able to work for a year. But it could also be 12 people having acute diarrhea for an entire month, or 24 people having diarrhea for 2 weeks, leading to one lost year of productivity, of contribution to the economy, of helping other people in your family, of going to school. So this is an aggregation of the impact on time, or time spent sick, in high-income countries. And the number 1 issue is heart disease. And you also see issues here like back and neck injury, or anxiety and depression and drugs, Alzheimer's, lung cancer. But if we look at the bottom grouping, it's lower respiratory infections and diarrhea and HIV and malaria that are the biggest causes of illness in developing countries. All right, another way of cutting this same data compares high-income countries at the top to low-income countries at the bottom, but for deaths in children under 5 in 2016. If you were born in a developed country or a high-income country, congenital defects and preterm neonatal complications are your biggest risk. If you were born in a developing country or low socio-demographic income country, index country, it's respiratory disease, diarrhea, malaria. I know I'm being a little bit repetitive here, but these are the stark disparities between high-income countries and low-income countries that impact health. 5.6 million children under the age of 5 died in 2016, 15,000 children every day. And again, 99% of the children under the age of 5 who die every year were born in low and middle income countries. All right, we're going to switch over and actually look at the global burden of disease visually. This is the Institute for Health Metrics and Evaluation website, healthdata.org. And these guys are based out of the University of Washington with support from the WHO and the Gates Foundation. And they aggregate this data and display it and provide access to it. So this is their GDB Compare, Global Burden of Disease Compare tool. What we're seeing here is globally all causes of illness or DALYs, disability adjusted life years for all ages. But let's do a comparison. Let's compare by location, and let's set the top chart to high income countries and the bottom chart to low income countries, as we were just looking in the PowerPoint. And let's look at only under the age of 5, and let's look at only deaths. So again, we see deaths in children under the age of 5 in low-income countries are going to be respiratory infections, diarrhea, and malaria. And in high-income countries, preterm neonatal complications. Let's see what happens, though, if we make it past the age of 5 and we make it over the age of 70. You start to see that causes of death start converging. If you make it past the age of 5, if you're a 70-year-old man or woman in a developing country, you may die of the same things that you might die of if you live in the United States or in Europe. Heart disease and stroke. So you can see that the risk factors are much more acute for when you're a child. These are the bigger issues, and you're much more likely to die or be exposed to respiratory disease and diarrhea and malaria and other issues when you're younger. You're going to use this website during several of the assignments throughout this course. So if we look at the determinants of health, we've covered a few of them already. Genetics, age, gender, lifestyle choices, community influences, income status, location in the world or even within a country, if you're in an urban or rural area, the impacts on health change. Urbanization is a trend in impacting health. Climate change is exacerbating already acute health disparities, and it's getting worse for many people in developing countries in particular. Governance matters. As you can imagine, more highly responsive and functional governments are able to provide basic services like water and sanitation, as well as health care and clinical visits and medicine. Environmental factors that we've discussed, air quality and water quality, work conditions, which are becoming increasingly important as globalization means that we have factories in developing countries providing goods in developed countries. And there are multi-sectoral dimensions of these determinants of health. For instance, malnutrition makes you more susceptible to other diseases and less likely to recover from other diseases. The behavior or the cultural behavior of cooking with wood and charcoal in particular, which is done by about 3 billion people every single day, leads to increased lung diseases and other respiratory diseases. Poor sanitation can lead to increased intestinal infections and less resistance to infections. And poor life circumstances can lead to things like commercial sex work and the associated STDs that are tied to sexual activity. And then cultural and regulatory issues like advertising tobacco and alcohol, we've seen this in the United States, can lead to addiction and related diseases and increases. And one that's happening as urbanization is increasing, road accidents are increasing in terms of numbers and as a cause of death worldwide. Another macro level issue is governance and institutions. As you can imagine, more highly functioning governments are better able to provide access to water, sanitation, health services. They can control policies, including trade policies, labor practices. You can address regional issues and allocation of resources. But one thing that's important to highlight here is that democracy doesn't necessarily mean high functioning government. And autocracy doesn't necessarily mean corruption. There are certain ideals and values that we have in the global north or in Western countries that don't necessarily translate to improved health and economic growth in some developing countries. It's a very complex issue. You can have autocratic governments that are highly responsive and are transparent and are low corruption, and you can have democracies that are really messy and don't provide positive or very high quality health services. And you can see a lot of this playing out in Africa in particular. Over the past 70 years, as most African countries have thrown off colonial rule, you can see disparities in how countries have created new governance structures and how those governance structures have reflected in the health of their people. Armed conflict is another macro level determinant of health disparities. The disparities over resources and power can lead to massive displacement of people and refugee crises, and often refugees end up in other neighboring countries that are also poorly equipped to deal with them. This can lead to malnutrition, exposure to issues like diarrhea and respiratory infections, increased transmission of HIV and AIDS, and long-term negative cultural, social, economic, and health impacts. And of course, climate change. Climate change is exacerbating some of these already existing disparities. In high-income countries, we expect to see an additional 2 or 5 deaths per million people that can be attributed to climate change. And in low-income countries, it can be as much as 40 times that. 40 times more people will die because of climate change in developing countries than in developed countries. Some of this is reflected in natural disasters like flooding and extreme weather events, the tsunami in Indonesia in 2004, or other natural disasters that you can't blame on climate change, like the earthquake in Haiti that nonetheless impacted Haiti dramatically, much more dramatically than it would have in some developed countries that have better services both to respond to the disaster, but also to prevent the destruction that happened, which in large part, especially in Port-au-Prince, can be attributed to poor governance and poor regulations around construction. And globalization, which is a macro level issue, directly impacts health. As trade increases between low-income countries and higher-income countries, that good and bad things can happen. Countries can increase in wealth, increase in access to services and education, in materials and products that improve health and improve livelihoods, but it can also lead to exploitation and resource transfer. And these are things, you can see all the different resources and countries that are involved in producing your Starbucks coffee. And globalization is neither good nor bad for health necessarily. It depends on how it's translated down to a sector level and a regional level and a country level. That concludes part 1, which is just an overview of global health. And over the next couple lectures, we're going to dive into some examples, epidemiology, and then the nature of some interventions. In part 2 of our introduction to global health, we're going to go into a few examples of diseases that disproportionately affect people in developing countries. Communicable diseases are defined as a condition which is transmitted directly or indirectly to a person from another infected person or animal through the agency of an intermediate animal, host, or vector, or through the inanimate environment. Transmission is facilitated by the following, which can include more frequent human contact due to increase in the volume and means of transportation. So this is things like air travel and urbanization, microbial adaptation and change, breakdown of public health capacities, such as through economic, political, or armed conflict, and changes in human demographics and behavior, as well as economic development and land use patterns. All of these can change the density of communicable diseases and the rate of transmission. There are different modes of transmission of communicable diseases. Direct transmission can be bloodborne or sexual, such as transmitting HIV and hepatitis B and C. Inhalation transmits tuberculosis, influenza, and anthrax. Foodborne disease that you've probably all been exposed to at some point in your life can transmit E. coli and salmonella. And contaminated drinking water can transmit cholera, rotavirus, hepatitis A, and other diseases like cryptosporidium. And then there are indirect modes of transmission, such as vector-borne. A vector is something like an insect. A mosquito is a vector for malaria. And then there's also zoonotic diseases that are transmitted through handling of animals and feeding of livestock. Communicable diseases account for a significant percentage of the global disease burden. They account for about 30% of the global burden of disease and 60% of the burden of disease in Africa. And they typically affect low and middle income countries disproportionately. Communicable diseases account for about 40% of the disease burden in low and middle income countries. Most of these diseases are preventable or treatable. And we're going to go into a few examples of these diseases. Communicable diseases can have a significant social impact. They can disrupt family and social networks as people are sick, especially if there's stigma attached to a disease like tuberculosis or HIV, AIDS, or leprosy. There can be discrimination in employment, exacerbating existing disparities. And they can create other social issues such as orphans or exposing children to other risks such as exploitation and sexual trafficking. Communicable diseases also significantly impact the economies in affected countries. For instance, through decreased revenue for a country, the estimated cost of the SARS epidemic in 2003 was about $20 billion, or about $2 million per case. Malaria, which is the single greatest killer in all human history, causes an average loss of 1.3% of annual GDP in countries with significant transmission. And at the household level, poor households in communities are disproportionately affected. They often are exposed to these issues. For instance, a mud hut is going to have more transmission of malaria and mosquitoes than a more well-built home. They may also not have running water or water treatment or safer sanitation or safer forms of cooking. So if you're poor, within a community, you are more likely to be exposed to these issues, and you're less likely to be able to recover from them. You probably have less social capital, political capital, economic capital to seek treatment. So here's a few examples of diseases that impact developing countries disproportionately. Air quality is an environmental hazard that can lead to disease, such as lower and upper respiratory infections and pneumonia. 85% of the world's population lives in areas where the World Health Organization guidelines for air quality are exceeded. And it's air pollution is the number 4 risk factor for deaths globally. And we see here a representation of both indoor air pollution, shown with the yellow house, and outdoor air pollution with the blue cloud. In India, in 2013, there were about 920,000 deaths attributable to indoor air quality issues and almost 600,000 deaths attributable to outdoor air quality issues. And in China, similar numbers. Globally, about 5.5 million deaths were attributable to air pollution, indoor and outdoor air pollution, in 2013. And it's about the same today. Water. No other single intervention in the history of medicine has saved as many lives and has reduced as much suffering as the provisioning of uncontaminated water, which is a sentiment that I agree with and is backed up by a lot of literature. And yet still today, over 1 billion people in the world lack access to safe drinking water. Now, the official numbers from the UN say it's closer to 700 million people, which is still a lot, but that number tends to hide unreliable access to water that only runs occasionally, maybe half the time, or water that is contaminated. And so, in fact, the way we're measuring this problem underestimates the impact. It remains unsafe water, remains one of the leading causes of diarrhea and death worldwide. 15 million children die every year from acute diarrhea, which is a combination of contaminated drinking water and poor sanitation. And if we look at the sanitation issue, billions, more than 2 billion people globally don't have access to safe sanitation, which are simple things like pit latrines or provisioning of drainage, disposal of waste, control of insect and rodents, or hand washing, access to soap and water to wash your hands. Billions of people don't have these basic services, and it's one of the leading causes of illness and death globally. And then, of course, malaria. Malaria has killed more people in human history than any other cause. Malaria is a parasite. There's actually 2 different kinds of malaria parasites that are carried in mosquitoes. And every year, about 500 million people become severely ill with malaria. More than 1 million people die of malaria every year. And 40% of the world's population is at risk of malaria. Most of these causes and deaths occur in sub-Saharan Africa. So you can see here malaria cases per 100,000. This is a little bit old data, 2004, but again, this is a persistent and chronic issue. And you can see that most cases are in sub-Saharan Africa. Now, control of malaria has been very successful in other countries. We have no malaria in the United States. I don't know if there's any cases. At least at best it's a handful every year, and usually that's people coming back from Africa or Southeast Asia. We did have malaria in the South, and we dealt with it by spraying. We dealt with it by spraying using DDT predominantly and eliminating mosquitoes, and also eliminating standing water. So doing drainage and getting rid of standing water had a significant impact on eliminating malaria in the United States. Now, DDT is very effective at eliminating malaria because it eliminates mosquitoes, at least for a while. The mosquitoes come back, but the parasite doesn't, as long as you get a significant coverage. As long as you get most of the mosquitoes, the rest of the malaria dies off. But this is an example of where a public health issue clashed straight into an environmental conservation issue. There was a book called Silent Spring that was published in the 50s that highlighted the environmental impacts of DDT, or at least the perceived environmental impacts of DDT, the idea that it was killing all the birds, Silent Spring, and it was impacting their eggs and the durability of their egg shells. And due to that outcry, DDT essentially was banned globally. And it was actually in the middle of a WHO campaign to spray Africa and Southeast Asia. And the combination of poor management of that intervention and the global outcry against DDT meant that they abandoned it. And as a result, hundreds of millions of people have been exposed to and gotten sick from malaria since then. So it's a good example of where there was this public outcry that seemed to be tied to a very righteous cause of environmental conservation that led to some really unfortunate downstream effects. Early diagnosis and prompt treatment can cure patients and also reduce the parasite reservoir. The fewer people that have malaria, the fewer people are going to get malaria. And vector control of that mosquito can include spraying, that actually should say residential spraying, and provisioning of long-lasting insecticide-treated bed nets that can, the most dangerous mosquito bites at night, and if you are sleeping under a bed net, you are much more likely to not get malaria. And there are certain challenges in malaria control, the biggest one being the global resistance to political resistance and social resistance to spraying. And then also the malaria parasite is actually becoming resistant to the most conventional anti-malarial drugs. All right, on to our next big issue, HIV and AIDS. This is a global estimate of HIV and AIDS mortality, deaths, and incidence in both sexes over the past roughly 30 years. So you can see that peak infections of HIV occurred in 1997, about 3.3 million infections, and peak deaths occurred in 2005 of 1.8 million. We've since about leveled off at about 2.5 million new infections per year. 75% of these new infections occur in sub-Saharan Africa, and about 1.2 million deaths annually. HIV development assistance, which what that means is providing education and contraceptives, or condoms, not contraceptives necessarily, to low-income countries, but more than any other thing, antiretrovirals, so drugs for treating HIV infections, has increased almost tenfold between 2000 and 2015. The PEPFAR program was started by President Bush, and then dramatically expanded by President Obama, and it's probably one of the most successful public health interventions in our lifetime of reducing disease transmission and reducing death. This shows the global HIV and AIDS burden, again, predominantly in China and Russia and sub-Saharan Africa. Sorry, that's Russia up top there, and sub-Saharan Africa are the biggest areas exposed to HIV burden. This data is a little bit older, but about 40 million people were living with HIV in 2005, 2/3 of whom live in sub-Saharan Africa. That disparity is still true. HIV and AIDS don't ultimately kill you. The vast majority of the time, it's your lowered immune response and immune system that makes you more susceptible to other infections and death from other infections. In particular, tuberculosis considerably shortens the survival of people with HIV and AIDS. And tuberculosis kills up to half of all AIDS patients worldwide, and it actually accelerates the progress of the AIDS infection. HIV and malaria is another example. They tend to be associated with poverty, and HIV-infected adults are at risk of developing more severe malaria because of their immunocompromised systems. Another example that you might not suspect is just waterborne disease. Cryptosporidium is a parasite in water, and HIV-infected adults and children are much more susceptible to acute diarrhea caused by Cryptosporidium than people that are not infected with HIV. So that concludes just a brief overview of some of the examples of diseases that disproportionately affect people in developing countries. This is part 3 of our introduction to global health and focuses on an introduction to the field of epidemiology, which is the discipline that focuses on studying disease and studying disease transmission within populations. So the first epidemiologist was a doctor named John Snow, who was curious about the transmission of cholera in London in 1854. And it's a pretty perfect example about the first version of epidemiology that established the field. Really was a combination of engineers, doctors, the new idea of epidemiologists, and public policy makers working together with people to identify and then try to control a disease. So this is a water pump in 1854 in England, and people were getting their water from the Thames. There were 2 water companies, and they were both drawing water directly from the Thames, which is also where raw sewage was going. So we know today that that's a bad idea. At the time, they didn't know. They thought that a lot of disease, like cholera, was transmitted through miasma, through the air. And there are, of course, diseases transmitted through the air, so it's not a crazy idea. But this ended up being a mode of transmission. Sewage went into the Thames, was pumped through the pipes. People got their water from hand pumps, and they went home and they got sick. 1854 and today. Hand pumps are actually still a source of water for hundreds of millions of people in the world, many of them in Africa. And still, hand pumps are a source of contaminated drinking water for many, many, many people. John Snow, when he was looking at disease incidence, he started a map. This is John Snow's map of the neighborhood in which people were getting sick. And every one of these little lines, you can see the little lines, is an incidence of cholera. And so he looked at all the patients coming into his office, and he asked where they lived, and he drew a little mark on this map to figure out where the disease was coming from. And he saw that the disease incidence was focused around the Broad Street pump. You can see a huge incidence of cholera right around this pump. So he figured, I think cholera is coming from the water. I think that people are getting sick from this particular pump. And he came up with the first ever intervention, public health intervention, which was this. He took the handle off the pump. That's why that pump is still there in London today. And you can see it doesn't actually have its pump handle. It sits there as a tribute to John Snow as the father of epidemiology, taking off the pump handle, and guess what? Cholera disappeared from that neighborhood. So this is basically still exactly what epidemiology is today. Epidemiology is concerned with looking at the causes of death, which can be obtained from a variety of sources, including surveys and death certificates, trying to establish life expectancy based on disease risks and factors that a population might be exposed to, looking at things like maternal mortality rate, the number of women who die as a result of childbirth per 100,000 live births, looking at things like infant mortality rate, the number of deaths in infants under the age of 1 per 1,000 live births, the neonatal mortality rate, the number of deaths in infants under the age of 28, and the child mortality rate, the number of deaths under the age of 5. So these are the measures of health status that epidemiologists predominantly are responsible for identifying, collecting, and studying. These next few slides are going to look a little different. I've stolen them from the CDC with permission to help make all of our lives easier. Epidemiology is the study of the distribution and determinants of health-related states among specified populations and the application of that study to the control of health problems. So figuring out what the problem is and what's causing the problem, and then proposing and studying what are called interventions to try to address that issue. And what's important about epidemiology is it's based on fieldwork, surveys, interventions, studies, on a population level, and statistics are a huge part of this. Statistically, what are you most likely to be sick from or get better from? It's not an individual level care. It's not about doctors and nurses treating people at a clinic or hospital level on an individual basis. It's about looking at population level issues. So epidemiology is designed to discover the agent, host, and environmental factors that affect health, determine the relative importance of causes of illness, disability, and death, identify segments of populations that have the greatest risk from that specific cause of ill health, and then evaluate health programs and services in improving public health. So to solve these types of health problems, epidemiologists use a 4-step scientific approach that includes looking at data collection, assessing and analyzing that data, developing and testing a hypothesis, and then proposing and implementing interventions, actions that can try to impact health. Here's a few key terms that epidemiologists use. And this is important in our course because we rely heavily on studies that help tell us if the water filter we invented impacts health, help tell us if that brand new cook stove that reduces air pollution in the lab actually translates to reduced respiratory disease in the field, if an insecticide-treated bed net that can kill a mosquito, or if people are actually using it sufficiently to reduce malaria transmission. So key terms include epidemic or outbreak. These are disease occurrences among a population that is in excess of what is expected. That's key. An outbreak is something that goes above the statistical norm. And you might see this, sometimes this pops up in the news, of cancer clusters, and people suspect that it might be because of the chemical plant nearby. It may or may not be. It may be a statistical anomaly or just bad luck, or it may really be tied to the chemicals that the plant's putting into the water. And epidemiologists will come in and try to establish that statistical chain. That's a cluster of disease incidents that they might study. And then an important term that you'll see in all the literature we're reading is rate, the number of cases occurring during a specific period, which is dependent on the size of the population during that period. So here's a rate formula. To determine the rate, we have to determine the frequency of disease, which includes the number of cases of that illness or condition that we're studying. Might be cancer, might be road accidents, might be malaria. The size of the population that is at risk, and the period of time over which we are calculating this rate. So here's a good example of epidemiologists in action. This is unexplained pneumonia that was observed at the American Legion Convention in Philadelphia, Pennsylvania. So between July 21st and July 24th, the convention was being held, and after the convention, there were 18 deaths reported among the conventioneers, which is pretty high. 18 deaths out of that population suggests that there might have been, suggests at least, that that's a cluster that could be caused by something that happened at the convention. So healthcare providers at the Veterans Hospital in Philadelphia called the CDC and to report cases of this respiratory disease among these attendees. And subsequent to this, 71 additional cases were identified. This was a cluster. This was a cluster that called in the CDC, Epidemiological Investigation Service, the EIS. These are the James Bonds of the CDC who flew in, started studying this, and they identified what is now known as Legionnaire's disease. They were able to trace it back to that convention and say that there was a specific cause that all of these other cases were at least likely to be connected with. So there's a few different types of epidemiological studies. In an experimental study, the investigators can control certain factors within the study from the beginning. So an example of this type is a vaccine efficacy trial that could be done at OHSU, the Oregon Health and Science University. In such a trial, the investigators randomly control who receives the test vaccine and who does not, and then they observe the outcome to determine if there's been a positive impact. So this is called a randomized control trial. In a randomized control trial, you get a lot of people together who might have a certain risk. So they might have diabetes, or they might all have a certain type of cancer, or not, or they could all be healthy 20 to 30-year-old adult females if you're studying something like the impact of exercise or the impact of nutrition on health. And you take people that are basically all the same, at least on an overall basis, and randomly allocate them to the control and intervention groups. So essentially, differences between people are washed out through randomly putting them in different groups. And you have to have a big enough study sample size, big enough number of people to make that viable. And in the control group, they don't get any treatment, or they might get the status quo treatment, currently the best drug on the market. In the intervention, they get the thing that you're trying to study. They get the new drug, they get the exercise regime, they get the education, they get whatever it is that you're trying to figure out if it makes a difference. In a blinded trial, which can't always be done, but when it can be done, in a blinded trial, the participants, they don't know what they got. They don't know if they got the sugar pill. They don't know if they got the fancy new drug. In a double-blind trial, the people actually running the trial also don't know. They don't know if they've handed out the sugar pill or not to these different people. And it's only after the study's over that you open the envelope and you put people in their groups, and then you say, oh yeah, look over here. The people that got the fancy new pill are 20% healthier or have 20% less incidence of this disease, or lost this amount of weight. The people over here lost 10 pounds, and the people in the control group only lost 2 pounds. Can't always do a blind trial, but it helps control for biases and the placebo effect. Then there's also observational studies. In observational studies, epidemiologists can't control these circumstances, and you can further divide observational studies into descriptive and analytic. Descriptive epidemiology is the more basic of these categories and is fundamental to what epidemiologists do. They collect information on what's going on and then summarize the health event or problem, like the study of Legionnaire's disease. So here's an example of a randomized control trial. In this randomized control trial, this is our program in Rwanda, which you're going to hear about later in the course. We provided water filters and cook stoves to about 100,000 households in the western province of Rwanda. So this is all the people in the poorest quarter of households in this entire region in dark blue. And we randomly, on a sector level, so these are sectors that you can see highlighted. These are administrative boundaries like counties that we have here. In these sectors, we randomly assigned 24 of them to the control group. So for an entire year, throughout 2015, the people in the control group did not receive our water filter and stove. Now, this wasn't a blind trial or a double-blind trial. Everybody knows who got the filter and stove and who didn't. But we were able to compare, or our epidemiology colleagues were able to compare pneumonia and diarrhea and air quality and water quality between the people in yellow and the people in blue to try to establish if our program impacted health. That concludes our very brief intro to epidemiology. Of course, if you want to be an epidemiologist, you would take a whole host of courses and get an MPH or a PhD in epidemiology. My team includes epidemiologists, and we work with those professionals in other closely related fields like biostatisticians to help us improve the nature of our own work. And so the public health world and the global health world is in large part driven by what epidemiologists are helping tell us what works and what doesn't work. All right, in our final part of our introduction to global health, we're going to start talking about interventions. Interventions are technologies, practices, policies, educational tools that are trying to impact positively health. So trying to reduce disease burden of a specific target or disease or group of disease. So a goal of intervention is to develop strategies for particular groups to engage in positive change towards improved health, and to provide a support system, a structure around that to initiate the changes and sustain the positive behaviors that are necessary to impact health. Sometimes it can be getting vaccines out there. So you can do a huge public health campaign to inoculate everyone against hepatitis. That's a public health intervention. Another one might be educational policies or public service announcements in communities, or providing training for community health workers, or providing technologies like water filters or stoves or bed nets, a whole variety of different types of interventions. A public health approach to an intervention includes looking at establishing what the problem is. You have to know what you're targeting, identifying the causes of those disease problems, evaluating interventions to establish what's going to work and what isn't, and then implementing interventions at scale. There's a variety of approaches and motives for different interventions. Some advocate for personal responsibility in action, that if there's sufficient access and education, that people should be personally responsible for their own health. And this is reflected in healthcare policies and intervention policies in many different countries, including our own. Others advocate for a utilitarian approach, which advocates for the greatest good for the greatest number of people. So that can include non-health system interventions, such as public policy or provisioning of technology or services like water and sanitation, without necessarily requiring personal buy-in or action and saying, look, this is the most cost-effective thing to maximize the most good for the greatest number. And that rationale also will lead you to prioritizing certain diseases that are easier to address than others. Other approaches include regulations and laws and policies that can be very effective at achieving a positive health impact. So, for example, anti-smoking laws or policies that encourage public transportation. And there are also partnerships and collaborations through multilateral organizations or the social sector, nonprofit sectors that provide services that may otherwise be thought of as inherently governmental. And another motive is enlightened self-interest. This is a little bit funny, but the idea here is that the more people that are brought out of poverty and poor health globally, the more trade there will be and the better it is for everyone involved. So it's not necessarily... It doesn't have to be motivated by altruism. We can engage in this work to try to improve the health and livelihood of others because it also benefits us in the long run too. So how do you run an intervention? What are the considerations? Education and knowledge is, of course, important in many cases. Developing a favorable attitude towards a positive health behavior or adoption of a technology. Providing training of trainers, such as community health workers and other folks that are closer down to the source of the problem, engagement in communities and actualization of community structures to achieve a health outcome, providing access to services, so providing access to water, sanitation, energy services, providing access to education, roads, transportation, clinics, hospitals, all can improve health. Using the underlying skills of local communities and providing supportive environments, including families, organizations, community leaders, and policymakers that can help result in the adoption of a healthy behavior or a healthy technology or a healthy policy. So there's often a question that comes up from people that are entering this field of why don't people change their behavior? Why are people drinking dirty water? They have a water filter. Why don't they use their bed net? Why don't they go get their kids vaccinated? And it baffles a lot of people. Behavior change is not just about personal knowledge. It took a generation almost to reduce smoking significantly in the United States, and it's taking another generation to get people to reduce their consumption of fast food. It's not just personal knowledge that matters. It's also access to resources. It's things like making the healthy behavior easier and more rewarding culturally and socially, and making the unhealthy behavior harder, or even deliberately stigmatizing an unhealthy behavior, like making smokers walk outside in the rain. So why don't people change behavior? They might know that a healthy behavior is better for them. They might understand it, they might have access to it, and yet they still don't change their behavior. So of course, do they understand the message? Do they think they're vulnerable to it? Do they trust the people that are preventing the message? Is it too costly in terms of time or money? Does change contradict with their religious beliefs or cultural beliefs? And, more than anything, is it kind of a pain in the butt? Is it a little bit too much of a pain in the butt to carry clean water to the field rather than just drinking water out of the hand pump next to the field? Or is the malaria bed net cumbersome? Or are the ARVs, antiretrovirals, too expensive? Or does it take too long to go to the clinic to get them? There's all sorts of reasons that people don't change their behavior that go beyond just access or knowledge. There are a variety of different models that behavior change specialists will use to try to develop interventions that result in a change in behavior, an adoption of a bed net, getting people to go and get vaccines or use a water filter. One that we've used is the health belief model, which looks at perceived susceptibility, so people's own perception of how likely they are to get the disease, their perceived severity, what people think is going to be the consequence of getting the disease, what their perceived benefits are of the behavior change, and the barriers to engaging in that behavior change. And then what triggers are necessary? What is it that people respond to get them to remind themselves to actually adopt the behavior change? And how confident they are that they're actually capable of that behavior change. I think we've all probably felt this at one time or another in our lives, trying to change our diet or study more, or exercise more. And these are the same challenges that people in developing countries face, but with much more dire consequences. So I'm going to give just an example of where we've translated this into action. There's going to be an entire lecture on our program in Rwanda, which at this point has been a 15-year process. But I'm going to give you just a piece of the puzzle, which is the behavior change tools, communication tools that we've used based on the health behavior model. So we distributed water filters and cook stoves to about 100,000 households, about 500,000 people, and a further million people received just our cook stove. And we needed to combine the intervention, the water filter and the stove, with this behavioral messaging tools. So the first step was to remind people about the consequences of dirty water. Most people know this already. It isn't that they didn't know, but some reminder is helpful. So where do people get their drinking water? Rivers, taps, springs, pumps. Sometimes this water is contaminated, and it can lead to diarrhea and cholera and worms and typhoid. So people are reminded first of the health impact, and we try to personify it, and we try to make it personal for individuals, for households. If they use our water filter that we've provided, there's less illness, and there's more time for studying, for working, for playing. And isn't that important to you? We then have to translate that to the action. Once we've convinced people that they want to be healthier and have less contaminated drinking water, they need to actually use it. And it's not easy. It's not automatic. It's an extra labor burden, especially for mom. She's got to pour the water in. She's got to wait some time. She's got to clean the filter. All of these actions are adding to her already very busy life before she can get clean water. So we need to constantly remind that person about what needs to happen. Similar on the cook stoves. Have you ever noticed any of the following when you're cooking? Headaches, coughing, dizziness, black walls. The black walls thing was actually interesting. That came out of our focus groups. All of this messaging we developed through focus groups and through field trials. The black walls was something people often identified as an eyesore. People didn't like it. So we highlighted that as an issue of cooking with 3 stone fires. And then we also showed how it's like smoking 2 packs of cigarettes a day, how it kills 12,000 children a year in Rwanda, damages the eyes, hearts, and lungs, and endangers the environment. This is another one that came out of our focus groups. Rwanda is almost entirely deforested. It's a major environmental issue, an economic issue in Rwanda, and the government of Rwanda has done a lot of work to educate people to reduce their use of firewood and cutting down trees. This came through in our focus groups, and we capitalized on that existing knowledge of the environmental issue to remind people that would be a benefit of using our cook stove. So we say you have the power to change with the cook stove. It uses less fuel, there's less smoke, there's less time cooking, there's healthier cooking. And then, of course, we provide the educational tools necessary to use the stove properly and consistently. We're going to go into much more detail later about the nature of these interventions and how we affected this behavior change. And then here's another piece. This is a piece that we left at home in people's houses. By the way, you're looking at the English versions of all of these. These are actually in Kinyarwanda, the language of Rwanda. This is a poster we left in people's houses where we customized it for that person. So our community health workers would go in and circle how many times a day does your family fill up the filter. If it's just one person, maybe it's once. If it's a big family, maybe it's 4 times. Do they do it in the morning or the evening? Depends on their family. And we help circle this with a Sharpie to customize it for the household. And then most significantly, we have this little contract on the bottom, and it says it's an agreement on receiving and using the improved cook stove and water filter. As a program of the government of Rwanda, my family received a water filter and improved stove to improve our health. We understand that using them every time will keep our family healthy. I am aware the equipment is not for sale and I'm responsible to maintain the equipment in my house. I am aware that if local authorities visit and the water filter and stove are not in my house, I will be responsible for paying the cost. This might seem a little heavy-handed, not going to work in every country or every community. Pretty effective in Rwanda. We found again through our focus groups and through working with many of the different partners involved that framing our program as a government initiative would be something that could be effective at getting people to adopt it. So the households sign it, and then so does a local authority. Not our team, but a local authority. And then another key thing here on the bottom, if you have a problem with your stove or filter, contact us at this short code, 8788. Again, we're going to go into much more detail later on this particular intervention, but I've included it in this lecture just to highlight how we've taken a technology intervention, stoves and filters, and combined it with the health belief model to achieve behavior change in households.